Do you see just the present mode now?
Yeah. Yep,
Okay.
that looks great. Okay, and we are live. Good afternoon, web shadowers. Thank you all for joining our session today. We once again have the pleasure of hosting Dr. Avi Varma, who will be presenting on family medicine. As always, please remember that the Google form for attendance will be posted in the chat box at the end of the session. With that being said, Dr. Varma, you can get started whenever you're ready.
Thank you so much, Sophia, and thank you, web shadowers, for asking me to come back and present. I had a great time last time, and looking forward to engaging with all of you. So I'm not sure, maybe the audience has changed a little bit, but basically I wanted to start by just introducing myself to those of you who don't know who I am, and talk a little bit about what family medicine is. So my name's Avi Varma, and I am a board certified family medicine physician. I went to the American University of Antigua School of Medicine in the Caribbean. I completed my 3-year family medicine residency training at Mount Carmel Health System, which is located in Columbus, Ohio. I then moved to Michigan with my family, where I worked for a large hospital-based healthcare system, and I worked as an outpatient primary care physician there. About a year and a half ago, my family and I moved to Atlanta, Georgia, and I have been working for a nonprofit organization here. And I care for patients that have HIV and AIDS, and I provide them with their HIV management medications, and I also take care of their primary care needs. On the side, I am a part-time master's in public health student, and so I'm currently attending the Johns Hopkins Bloomberg School of Public Health. Real quick, I have no financial disclosures. Nothing I discuss during this presentation is representative of my employer. And all cases that I discuss, I don't discuss details of the patients themselves. These are just cases that I've come up with based on previous things that I've seen in the past. So I just want to talk real quick about what family medicine is for those of you that don't know. Basically, in family medicine, we are primary care physicians that provide comprehensive and continuing medical care to potentially all age groups, depends on the physician and their preferences. But generally speaking, in family medicine, we provide care to all age groups, from the newborn baby age group all the way to the geriatric population. We provide preventive care services that includes health education, some of the cancer screenings like cervical cancer screenings. Additionally, we refer for preventive care services like colonoscopies as well as mammograms. And we make sure our patients are up to date on their vaccinations, which is very important. We also provide chronic disease management. So that includes conditions like diabetes, high blood pressure, also known as hypertension. We can perform minor in-office procedures. So if someone comes in with an abscess, which is a pocket of infection, we can actually incise it and drain it in the clinic setting. We can perform skin biopsies. So say you're doing an annual physical checkup and you want to do an annual skin checkup during that time, or if a person or patient is concerned about an abnormal appearing mole, we can do an assessment and we can biopsy it and send it off to pathology. And depending on the results, you decide what to do from there. We can also perform joint injections. So patients that have arthritis, chronic joint pains, we have the ability to do that as well. We also manage specialty referrals. So for example, if we have a patient that needs to go for a stress test, if they're having chest pains, you can refer them to cardiology. We refer to pulmonology, gastroenterology, you name it. But we can manage those referrals for our patients. And I like to think of family medicine as a home base. So we are the home base for our patients' healthcare needs. And from us, we kind of send them for care if there are things that we are not able to manage personally. So I just wanted to talk about some of the job opportunities for family medicine physicians. So Personally, I'm an outpatient primary care physician, so you can practice on an outpatient basis. You can also practice in the hospital setting. So there are a lot of hospitals that where family physicians can be hospitalists and perform inpatient medicine. Additionally, you can work in urgent care settings, even emergency medicine settings if you do a fellowship in ER. You can work in academics if you're interested more in teaching. And then you can also go on or pursue a fellowship opportunity. There's a question here. Do you have experience practicing family medicine in rural areas? So in my residency, I actually did an elective in rural medicine. The nice thing about those opportunities is you get to do a lot more. You get a lot more hands-on experience. So yes, I have. Was it for a long period of time? No, but I did work in a rural area, which was a great experience. And then I talked about fellowship. Now, in terms of what kind of settings you can practice in, you can work in large healthcare systems, you can work in community hospitals. And when I say, sorry, going back to large healthcare systems, it doesn't have to be in the hospital setting. It could be as part of their medical group outpatient as well. Community hospitals, rural hospitals or clinics, kind of like I was just asked about the rural areas. You can work in private practice. I know I have plenty of colleagues that started their own private practice or joined a private practice setting, and then you can work nonprofit, kind of like I do. Let's see, there's another question here. Was it difficult to match for residency since you attended school abroad? So I will say that the statistics show that it is harder for med students to match in residency if they apply from abroad. So if you're essentially a foreign medical grad or FMG or international medical grad or IMG, it means the same thing. And the statistics are about equivalent between students that are, US international med grads like myself, I'm a US citizen, and the non-US international medical grad statistics are about the same in terms of match rate. Match rate's about 60 to 61% compared to, I think it's like 94% if you go to medical school in the US. So it is more difficult, but it's not to say that it's not possible. It's very possible to match. So I kind of touched on fellowships, and if you want to see the full list, you can actually go to the aafp.org website. That's the American Academy of Family Physicians website. But here's a list of some of the opportunities and fellowships that are available to family medicine physicians. So addiction medicine is one of them. Adolescent medicine is another, emergency medicine, which I mentioned earlier, geriatrics, hospice or palliative care, integrative medicine, obstetrics. So if you're more interested in practicing rurally, for example, and you might have a higher chance of having to deliver babies, doing an obstetrics fellowship would be recommended. There's also a fellowship, I don't know if it's the same, but there's one in C-sections. So, for those high-risk cases that have to go for C-sections, you can get certified or trained in that. Sports medicine and women's health. And now how would women's health be different? It'd be more in terms of gynecology, essentially. So these are some questions that I commonly get asked. So I wanted to touch on them real quick before I kind of get into the cases that I wanted to discuss with you guys today. So why did I choose family medicine? So family medicine, what I love about it is that it is so comprehensive. I personally feel like I'm constantly learning something new. There's so much that goes into it, not just the fact that it's diverse in terms of the age groups that I get to see, but the kinds of conditions that I get to see are different, as you will see in the case presentations today. Additionally, I enjoy building relationships with my patients. So, oftentimes you'll get a baby and then you'll get the mom, or vice versa. You'll get the mom and the mom decides when she has a baby that she wants the baby to see me. I'll see couples, I'll see families in general. So I do love that kind of interaction. Another question I often get asked is, what is the difference between family medicine and internal medicine? So they are quite similar, but a big difference is the age groups that you can see. So as a family medicine physician, in addition to seeing the adult and geriatric population, you can see kids starting from 0 to 18 or 17. Oftentimes with internal medicine, they start seeing patients starting at the age of 18. So that's a primary difference. Another big difference is the fellowship opportunities. So internal medicine, traditionally, you can do fellowship trainings in cardiology, pulmonology, and so on and so forth. Whereas family medicine, at the previous slide, I mentioned the fellowship opportunities that are available through that. How long is residency training is another question. And I already kind of mentioned, so I did a 3-year program. That's pretty traditional. There are some programs that are 4 years, but oftentimes they're combined with something else, like a family medicine plus emergency medicine program. What does an average day in the life of a family medicine physician look like? That's another question I often get asked. I think it really depends on what you choose to do. So if you choose to do the outpatient route, oftentimes you'll find that the job is 8 to 5, 40 hours a week full time. In some cases, you may have early hours, like some clinics start at 7 a.m., some clinics close late at 7 p.m. to accommodate for more patients that are working full time and need, different hours or untraditional hours of care. In some cases, you may also do like a Saturday or something like that. So my job in Michigan, I would do one Saturday once every 8 weeks because we had a big group. So our physicians would rotate each Saturday, and the Saturdays were like 8 to 12. We would also have early and late hours, and we had to do one day early, one day late. Do you have work-life balance as a family medicine physician? I think that's definitely possible. I think it's possible in many specialties. It really depends on what you're looking for. In family medicine, if you're really looking for traditional 8 to 5, you can absolutely get that work-life balance. If you're like, I would rather work 1 week on, 1 week off, and that's your definition of balance, that's possible too, especially if you decide to do the hospitalist route, which is the inpatient medicine route. So hopefully that answers some of your your questions that you may have about family medicine. But those are generally the ones that I get asked. So I kind of want to get into the clinical case presentations if there's no questions in regards to family medicine. I haven't seen any other questions so far, so I'll just go ahead and get started. So the first case that I'm going to discuss is and I'll read this to you guys. So Miss A, she is a 26-year-old female who presents to the clinic 2 days after she fainted at work. She states that she's extremely busy at work, so she didn't get a chance to get evaluated sooner. For a patient like this who's fainted and they come into your clinic, you're obviously nervous. They've come in a couple of days later as opposed to presenting right away to be evaluated. She states that she was standing and assisting a coworker when she suddenly felt nauseous and started to sweat profusely. She recalls her coworker telling her that she looked pale before she passed out. She had a similar episode several years earlier. She denies any associated chest pain, shortness of breath, or palpitations. And palpitations are when you feel like your heart is racing really fast. Immediately after the event, meaning immediately after passing out, she had no post-ictal confusion. That just basically means that she woke up after passing out. She didn't feel confused right away. She was aware of what had happened and where she was. And she also didn't experience any urinary incontinence, which is just having an accident of urinating on yourself. The episode was witnessed by her coworker, who stated that she didn't exhibit any seizure-like activity when she passed out. So these are all very important points, and I will get into that a little bit more shortly. When you are seeing a patient, it is always important to do a comprehensive or gather a comprehensive history. You want to know what past medical history they have, meaning do they have any medical conditions that are currently being treated or that have been treated in the past. In her case, there have been none. She's also not had any surgeries. I always like to ask social history. Are they using any recreational or illicit drugs? Do they drink alcohol? Do they smoke cigarettes, marijuana? So she drinks alcohol, sounds like it's pretty socially, so one drink every other weekend. One thing that often gets missed when asking these questions is sexual history. Me being in HIV care, I've found it's very important, obviously, to ask these questions, and I feel that this is something that should always be asked of our patients. So she's in a monogamous relationship, family history, none. And generally, when you're asking family history, you're asking about immediate family. So you're asking siblings, parents, grandparents, mom's siblings, so aunts and uncles, dad's siblings, aunts and uncles, and grandparents on both sides. And you'll be surprised some of the things that you'll find out in that situation. Allergies, no known allergies to any medications, and she's not currently on anything. Okay, so in terms of her vital signs, that's what VS stands for. Her vitals look pretty good. Her blood pressure, I mean, some would say it's a little bit low, but she's a young woman. I tend to find blood pressures being around this range. Usually we think gold standard 120 over 80 or 120 over 70. I personally run around 100 over 70. I don't have symptoms like dizziness or lightheadedness. So for me, it's normal. And in this instance, the patient that presented will say that she didn't have any symptoms when she came in to see me in the clinic. In terms of the physical exam, it was pretty much normal. She did appear tired, but she also mentioned she's like has a lot of work on her hands. The big thing that I would monitor or evaluate on patients that have passed out is their cardiac exam and, doing a neurologic exam. So in her case, there are no murmurs. So she didn't have any abnormal rhythm of her heart, no murmurs or any abnormal heart sounds that I heard or anything like that. So what do we do next in this situation? You want to order blood work on the patient. So a couple things that I want to mention when someone has passed out or mentions that they have a history of passing out. And I already kind of explained this in the clinical presentation, but just understand that you don't always get that information from a patient. They may just come in and say, yeah, I passed out. So you have to ask key questions. Did you experience symptoms right before you passed out? What were those symptoms? How long had you passed out for? Do you know? Was it a witnessed episode where you passed out? Did you injure yourself when you passed out? Like a lot of times with syncope episodes, we worry about head trauma, for example. And when it was witnessed, did someone witness you having jerking movements or anything like that, or seizure-like activity, as I mentioned? Were you confused following the episode? How long were you confused for? Things of that nature are really important to ask. So in terms of labs, you want to order a comprehensive metabolic panel. So that includes things like electrolytes, like sodium, potassium, glucose level, kidney function, liver function. And then you also want to order a complete blood cell count to see if the patient is anemic or not. Now, one reason we really worry about syncope is something related to the heart. So we want to make sure that there is no cardiac abnormality. So that's where the rest of the history comes into play. So she didn't mention chest pain. She didn't mention any personal history of cardiac problems. She didn't mention any family history of cardiac problems, all important things to note. Regardless, I still recommend doing an EKG on these patients because you never know. Maybe they have an abnormal heart rhythm that you just happen to miss on the exam. Exam is in the moment, and so is an EKG, but it still can add to the picture. So it's important to do. In her case, her labs were normal overall. I've listed the numbers there. I'm not going to get into it, but they were all within normal range. Her EKG was normal as well, which is important. So in her situation, what would the diagnosis be? I would say vasovagal syncope. So I have a question here. Do you ever see patients that come in with emergencies or critical situations, or will they be immediately referred to the ED? So I think it really depends. So if the patient comes in and is passing out in front of you, you're obviously going to take care of the patient, stabilize the patient, and then send them to the ER. Any patient that comes in, honestly, I personally would examine, regardless of whether it's an emergency or not. So yes, that you do see patients that come in like with active chest pain. So you have to assess them, stabilize them, and then call for an ambulance to take the patient to the hospital. So yeah, it definitely does happen, and we do refer them, but we also assess them prior to that and make sure they're stable. Okay, so we talked about this. So I want to talk about syncope in general. So according to the American Heart Association, here's their definition of syncope. Syncope is a temporary loss of consciousness, usually related to insufficient blood flow to the brain. So it's commonly caused by low blood pressure, also known as hypotension, which leads to decreased oxygen perfusion to the brain, which is essentially you have low blood flow to the brain, so less oxygen to the brain. These episodes generally last about 8 to 10 seconds, and they're often self-limited, which means that they would resolve on their own. But causes can range. So they can go from benign, like in the situation of vasovagal syncope, like we mentioned with this patient, to very life-threatening conditions, which is why it's so important to do a full assessment on these patients and rule out more serious causes. And again, that comes back to history taking, understanding their medical history, and doing appropriate workup and a physical exam. So really, I wanted to talk about syncope today because it's quite a common condition that we see. In terms of lifetime prevalence of syncope, in the US, it's anywhere from 20% to over 35%. I looked at a lot of data and the numbers varied, but this is generally what I found. That's quite common. Vasovagal syncope itself, like I mentioned, is generally a benign cause of syncope. I do want to talk a bit more about the other types of syncope that we worry about, or the different, kind of the differential diagnoses. And let me know if I'm going too fast or too slow, guys. I can't gauge myself, so I would love to hear from you guys if you want me to slow down or speed up. Um, In regards to potential causes of syncope, we mentioned vasovagal syncope. There are other names for it. Also, it's also known as neurocardiogenic syncope or reflex syncope. Another cause of syncope is orthostatic hypotension. Now, remember I said hypotension means low blood pressure. Orthostatic refers to positional changes. So the definition is in the name. So having a low blood pressure or drop in blood pressure with position changes. And the way to diagnose it is seeing a decrease in systolic blood pressure, which is the top number of your blood pressure, of greater than or at least 20 points, or the bottom number or diastolic blood pressure dropping by greater than or at least 10 points with position change. So this is something you can do in the clinic itself. You have the patient lie down or in a supine position, you check their blood pressure, then you have them sit up, wait 2 minutes approximately, and then you recheck it. And if they have this significant drop, then you worry that, okay, they have a diagnosis of orthostatic hypotension. So what does that generally mean? Or what are the causes of orthostatic hypotension, and in what population do you tend to see it? You tend to see this more in the aging population, so the older population. You can see this in patients that are on blood pressure medications. They may unfortunately have a drop in blood pressure that can cause this condition. For example, if a patient's on a diuretic, also known as a water pill, or if they're on a beta blocker like metoprolol for their blood pressure, you can see this occur. Another really common reason is actually just simply dehydration. So when I have patients that come in with similar symptoms or syncopal episodes or pre-syncope, which means they had the symptoms leading up to syncope but they didn't actually pass out, I generally ask about hydration. I ask, what do you usually drink in a day? Where do you get like your liquid intake from? Is it water? Is it coffee? Is it tea? Is it, soda or pop, whatever you call it? So, I mean, I generally ask this because oftentimes I find that people do not drink enough water. So it's very important to discuss that with patients. One of the very serious reasons why you work up syncope, and I already kind of touched on this with the whole EKG situation, is cardiac forms of syncope. There are many reasons for that. It could be an irregular heart rhythm, like arrhythmias. One of them is like supraventricular tachycardia, which is life-threatening. So you need to that's why I recommend a baseline EKG. Obviously, if this patient had active chest pain, I'm going to be referring them to the ER as well. It's not something I'm going to say, let's sit on this and wait, let's see what's happened. So in these instances, what we usually do is we refer to cardiology. Say the patient had come in and said, I've also had my heart's been racing really fast, and I notice that I have skip beats or irregular heartbeats. Some people actually feel that they can feel that. So in those instances, I kind of err on the side of caution, and I say, let's have you see cardiology as long as they're not having active symptoms and the EKG looks good in the clinic setting. If it looks unstable or they look unstable, I send them to the hospital. I just want to make that clear. Now, in the stable situation, when you send them to cardiology or refer them, you hope, or what you want cardiology to do, and what they usually end up doing in these situations, is they usually do what's called a Holter monitor or an event monitor. Basically what it is, it's like a portable EKG that continuously monitors your heart rate and rhythm over a certain time frame. So Holter monitors are shorter in the sense that patients may wear it anywhere from 24 hours to 72 hours, oftentimes 24 to 48 hours. In some instances, cardiologists may say, you know what, that may not be enough time to capture this abnormal rhythm. And so they will put the patient on an event monitor, which generally is something you have to wear for 7 days. And you're really looking to identify a rhythm during any form of activity, or abnormal heart rhythm during any form of activity. Another cause of cardiac syncope is some form of structural or anatomical cardiac disease. So one thing to note, or one of the reasons or causes of structural, or what I say by that is like aortic stenosis is a form of structural cardiac disease, occurs generally in the older population. So basically it's, the aorta itself is narrowing, and that can lead to these syncopal episodes, which can be dangerous. So, if you're worried the patient is older, you hear an abnormal heart murmur, you do an EKG, shows potential changes you're concerned about, but they're stable, you send them to cardiology, and then hopefully they're going to do an echocardiogram, which is an ultrasound of the heart to look at the heart function and assess the structural anatomy of the patient's heart to determine do they have AS or not. Cerebrovascular disease is another potential cause of cardiac syncope. So when I say that, I'm referring to strokes. So again, it comes back to the history taking. And we already know in this situation, the patient was low risk for that, and her exam didn't show any findings of that. So moving away from cardiac causes, let's talk about neurological causes. So seizures, for example, which is why we ask about, was your fall or was your episode of passing out witnessed? If it was witnessed, did the person that witnessed your fall notice you having or experiencing jerk-like or jerking movements or seizure-like activity? Were you confused up to 30 minutes following the episode when you regained consciousness? Another thing or sign you would find is if the patient bit their tongue. You may even experience incontinence. So in this situation, the patient presents. Usually what I would say, if it's right after the episode, hopefully they're going to the ER. But unfortunately, there are a lot of cases where, I would see a patient in the clinic days later and they would say, oh yeah, by the way, this happened. Not saying it always happens, but it does happen. So what do you do in this situation? They seem safe at the moment. If they don't seem safe, then you would send them to the ER. But if they're stable, then you refer them to neurology, and then they would do an EEG to determine what is going on in terms of their brain activity, and are they diagnosing them with seizures? Do they need to be started on anti-seizure medication? Psychogenic pseudoseizures is another cause. So, and basically with that, we worry about like conversion disorder, which actually accounts for about 1% of these cases. So it's not a true seizure, essentially, is what I'm trying to say. Metabolic abnormalities such as hypoglycemia, which is low blood sugar levels, which can occur commonly in some patients. Someone comes in and says, I didn't eat all day, I was out in the heat, and I passed out, or I was shaky, I was sweating, I was nauseous, I felt very hungry, and then I ate something and I felt better. Things like that. And unfortunately, sometimes we don't know the cause of syncope. That is also a common reason. So syncope of unknown origin is a possibility as well. Going back to vasovagal syncope, so how do you treat or prevent it? So I will say I've seen some episodes where a patient looks like they're about to pass out in the clinic. For example, they're getting their blood drawn, they suddenly get very pale, they're getting sweaty. So what do you want to do in these instances? Obviously you stop the blood draw, but you want to make sure they don't injure themselves if they do end up passing out. So a lot of times I have them lie down. Another thing you can have them do is actually sit down and cross their legs. I personally experienced this when I was on rounds as a med student once, and I immediately left the patient's room and I sat down, crossed my legs, and I felt better within minutes. So those are things you can do to kind of combat that. Looks like another question here. Is it common for these episodes to occur in the morning after waking up? So it can happen any time of the day. But a lot of times when I hear morning after waking up, it's because a patient was lying down and then they suddenly sat up and they felt dizzy. So in that situation, I think more about orthostatic hypotension than any of the other conditions. So I'm going to move on to the second case and kind of go from there. Let's see here. And I do want to, I don't know where my phone is. I was going to check on time, but I'll keep going. So Mrs. B is a 32-year-old Caucasian female who presents to the clinic with decreased energy, sleep disturbances, and mood changes. She states that since it started getting darker earlier in the evenings, and since it started staying dark for longer periods of time in the mornings, that she has found herself to feel more down. She states she is more irritable and she feels that she often yells at her husband for no reason. Um, she finds comfort in eating sugary foods and has noticed an increase in her weight as a result. She recalls having similar or the same symptoms last year around the same time. She states she is tired of feeling this way and would like help to feel better. So in terms of, again, medical history, you want to ask the same kind of questions. The past medical history, she has a history of depression and anxiety. Past surgical history, none. Social history, none. Sexual history, she's married in a monogamous relationship with her husband. Family history, her mom has history of depression. She has no known medical or medication or drug allergies, and she's not currently on any medications, but she was previously on Zoloft for depression and anxiety. Okay. So in terms of her vitals and her exam, vitals are stable. Exam wise, I kind of bolded. The only things that really stood out was she looked sad. She was teary eyed. She made limited eye contact. She appeared depressed and anxious. So what do you do next in these instances? Obviously, we're concerned about her mental health at this point. And why am I talking about mental health as a family medicine physician? Just as a side, it's because we handle more than just chronic conditions, preventive health screenings, and such. We do a lot of mental health management in patients as well. And that's why I thought it was important to bring this up. So what do we do next? We do a patient health questionnaire, and I put 9. So I'll get into that shortly. You also want to order labs. So here's the thing is, I'm thinking she's depressed. That's my thought process so far. Okay. But you want to rule out underlying medical conditions. Oftentimes or sometimes patients may have another reason that explains their depression. And it's not just depression, it's they have hypothyroidism, which is a thyroid disease, or they're anemic. And so they're depressed. There's depression that correlates with that. So you want to do basic labs. You want to do a thyroid function panel and a complete blood cell count. So this is the screening tool that we utilize in the clinic setting. This is called a patient health questionnaire, PHQ-9. So generally we hand out PHQ-4s first when patients come in, and that's literally the first 2 questions on here. But before that, I want to say at the top, it says, over the last 2 weeks, how often have you been bothered by any of the following problems? So we're really assessing in the last 2 weeks. We're not asking lifelong symptoms. So number 1, little interest or pleasure in doing things. Number 2, feeling down, depressed, or hopeless. So as I'm going through the questions, I want you to think about this in relation to our patient. So she mentioned feeling down, right? Number 3, trouble falling or staying asleep or sleeping too much. She mentioned sleeping too much, or she was having sleep disturbances. Number 4, feeling tired or having little energy. She mentioned feeling tired. Number 5, poor appetite or overeating. She did mention, eating a lot of sugary foods. Number 6, feeling bad about yourself or that you are a failure or have let yourself or your family down. Number 7, trouble concentrating on things such as reading the newspaper or watching television. Number 8, moving or speaking so slowly that other people could have noticed. Or the opposite, being so fidgety or restless that you have been moving around a lot more than usual. And finally, and I put an arrow here because this is a very important question, is thoughts that you would be better off dead or of hurting yourself. Now, in terms of the questions, there's also a 10th one, and that's we often look at separately. If you checked off any problems, how difficult have these problems made it for you to do your work, take care of things at home, or get along with other people? In terms of the scoring system, the parts that are grayed out tend to fall more into a severe category of depression. So, based on the score, if you look at the bottom right hand side, it gives you an interpretation of here's the total score range that um, is categorized into depression severity. So, minimal, mild, moderate, moderately severe, and severe depression. And obviously, if you score anything on question number 9, you want to do further assessment in terms of safety of the patient. Are they having active thoughts of or a plan of hurting themselves? Who do they turn to for support? Who is their support system? Providing them with the appropriate resources. If the patient is deemed unsafe, you want to get them help immediately. You do not send them home. So I think this is a great tool. And in terms of this, obviously I'd be worried about depression in this patient. Now, she mentioned that she's finding it more with the season change. She had this similar episode last year as well. She has an underlying history of depression, all puts her at higher risk for seasonal affective disorder, or SAD or SAD. So SAD is a type of depression that comes and goes with season changes. And so I really wanted to talk about this time because this is generally the time frame when you notice more of these cases. It generally starts in late fall and early winter and goes away during the spring and summer. It's thought that SAD is due to changes in the amount of daylight during different times of the year. And symptoms actually can occur in the summer, although they are much less common than in the winter time. In terms of the US, approximately 4 to 6% of the population suffers from this, and an additional 10 to 20% may suffer from a milder form. I mean, that's pretty big. That's a big number. So it is quite common. That's why I find it important to talk about. In terms of symptoms, these are some of the symptoms. There are other symptoms as well, but fatigue, hypersomnia, which means oversleeping or excessive sleeping, overeating, especially craving sweets or carbohydrates, weight gain, social withdrawal, difficulty in concentration, irritability, loss of interest in doing activities or hobbies, hopelessness, feelings of guilt. So, let me see here. Okay. So in terms of treatment, there are different treatment modalities that can be utilized. So light therapy, we often think of when it comes to SAD. There's some data that suggests this could be helpful. And so it is something that can be utilized, but there's a way to use it. So basically, with the light therapy, it's generally something that'll be most effective if you utilize it in the morning time, ideally for 15 minutes to an hour. And you have to have the light propped up at kind of an angle to kind of hit you from the top side diagonally for it to really be effective. Other options are cognitive behavioral therapy, specifically behavioral activation, which basically means you help the patient, or the therapist helps the patient convert their negative thoughts and feelings associated with kind of the darker times of the year to more positive thoughts. General therapy and counseling, in some instances, the symptoms are so severe that you may even consider antidepressant medications. For the patient that I talked about, if you're to ask me, well, what would you do for this patient? She has an underlying history of depression. She was previously on Zoloft. I would ask her, when you were on Zoloft, did it help with your depression? And if it did, I might consider offering that to her. If she's like, I really want to avoid medication and find another way, I would suggest light therapy and probably send her for CBT as well, which is cognitive behavioral therapy. Vitamin D has been found to potentially help. There's some data that suggests that it can help with serotonin activity, which is the neurotransmitter that can affect or impact depression or lead to depression. Now, we talked about underlying medical issues. You want to make sure if there is some underlying issue that you treat that. You don't want to miss those things. Dietary modification, eating a healthy, well-balanced lifestyle. Avoid alcohol and drug use because like alcohol is actually like a depressing agent. So you want to avoid that as much as possible. Physical activity can definitely help improve the mood. Meditation. And, if it's a severe situation, although I haven't had to do this, you can refer to a specialist, you can refer to psychiatry if you have to. And so I'm getting some questions here about SAD. Is it often that patients become suicidal due to SAD? Do they often get referred to psychiatrists? So yeah, the psychiatry bit is more if it's a situation where you're like, I don't think I can handle it, or they're actively suicidal, you send them to the ER, they get admitted inpatient psych, and then they have a psychiatrist that's managing them. Is it often that they're suicidal? I don't know the exact rates, but generally speaking, someone who has severe symptoms or a high score on their PHQ, I would monitor on there to see if they're suicidal. I don't have exact data for you to say that they are at higher risk, but generally it's more so they have an underlying history of depression, and then they have SAD, or symptoms are worsened during this time frame, and then you'd be more concerned for it. Does SAD have different prevalence in males versus females? I believe it's higher. It's 4 times higher in women than in men. So yes, there is a difference. Does melatonin help with SAD patients with issues sleeping? I've actually seen some opposite data out there, and I'm happy to look it up and get back to you guys on that. But I've seen some opposing data to that. So great questions, you guys. Keep them coming. So yeah, that's SAD. And actually, I apologize, I missed a question about syncope. So I'll go back to that case real quick. How often do you find that patients have syncope of unknown origin? Not often. Usually we find a cause. So I don't often find that to be a diagnosis. Can it be? Yes, but I don't often see that. I usually see that it's vasovagal, due to some metabolic abnormalities. So hypoglycemia are probably the 2 most common reasons. The next would be orthostatic hypotension, and then cardiac syncope would be the next one, which is obviously more severe. All right, so so I have one more case. I don't have all the details, but I really want to touch on this because I wasn't sure on time how we were going to do. So it looks like we're pretty good though. So I do want to spend some time talking about this because this is really what I do. So Mr. C is a 21-year-old African-American male who presents for a checkup. He states his partner told him that he recently tested positive for chlamydia and informed him to get tested. The patient denies any current symptoms initially, but would like to get a full STD check. This is key because a lot of times patients will come in and they'll say they're feeling good. You have to probe them. You have to ask them questions because you may find that they'll actually have some symptoms and they just didn't really think about it in the moment. So this does happen often. Same thing when you go through medical history. Sometimes I'll find a discrepancy where my medical assistant will go in and the patient will say, I don't have any medical conditions. And then I walk in there and I ask them the same thing. They say, I don't have any medical conditions. But then when you ask them if they're on medications, they say, oh yeah, I'm taking X, Y, and Z. So unfortunately, this happens, but that's why you have several checks when you go through, and you really have to ask a lot of questions. So that's definitely key. Anyways, moving on. He states that about a month ago, he had flu-like symptoms, including fevers, chills, body aches, and a decrease in appetite. So in this day and age, what are we worried about with those symptoms? Well, we're worried about COVID, right? But you could also have the flu. So he states he got tested for flu and COVID and that was negative. So just as a side, I threw that in this case because I don't want that to be the focus of the case. Now, in reality, you need to know when that COVID test was. I mean, it's been a month. Are they having any active symptoms at this time? Those are really important questions to ask as follow-up. But going back into the case, he states those symptoms have resolved, but then on further questioning, he does feel fatigued and he's noticed swollen lymph nodes in his neck. Okay, there's one more question real quick about SAD, so I'm going to quickly address that before I move on. As a PCP, are you the one writing the prescription if the patient needs antidepressants? Yep. Yeah, I do a lot of mental health management. It's something that we get trained for in residency, so you don't have to send patients to a psychiatrist for that. Obviously, if it's a complicated case, for example, Patient says they've been on 5 different antidepressants in the past. None of them have worked. You get a full history and you're not finding a drug that may be beneficial for the patient and you need extra help, you send to psychiatry. Psychiatry is such a great resource. They're amazing at what they do, but it can also be very difficult to get patients in with a psychiatrist just because we have limited access to care. We just have, we need more psychiatrists. So fortunately, as family medicine, we have some training in mental health, so we are able to manage some of these cases. So yes, I do that all the time. Going back to this case, again, this case isn't structured the same because I wasn't sure how much time I had, but I'll go through whatever is here. He doesn't have any past medical history or surgical history. He smokes 1 pack a day of cigarettes, and he has been for the past 3 years. In terms of sexual history, he's MSM. He has had 3 sexual partners in the past year. He doesn't have family history. NKDA just means no known drug allergies, and he's not currently on any medications. So what do we know so far? He has a potential exposure to chlamydia. He had flu-like symptoms a month ago, which have resolved mostly, but he continues to experience some fatigue and he has some swollen lymph nodes in his neck. He also is MSM, so that's important to note as well. So in my clinic, what do I worry about? Sorry, MSM is men who have sex with men. So this is not usually how patients present to me in the clinic because all of my patients that come to me have already been diagnosed with HIV. This I'm bringing up because it's important for physicians that are primary care. If they see things like this, they have to test patients for HIV. So let's talk about HIV. So in terms of the US, approximately 1.2 million people live with it. Approximately 14% don't know that they have HIV. That's 1 in 7 people. HIV continues to disproportionately affect certain racial and ethnic minority groups. Highest prevalence is in men who have sex with men, or MSM population. And the groups that are most affected, unfortunately, are African Americans and the Hispanic population. In terms of treatment, obviously for this patient, before I get into that, I want to talk about what would you do for workup. Like I said, I didn't make the slides the same way, so I apologize for that. So the patient mentioned chlamydia. You want to do a gonorrhea chlamydia check on this patient. If we know they were exposed to chlamydia, they're not having symptoms, you test them. If it's positive, you go ahead and treat. Generally, treatment for chlamydia is azithromycin. It's a one-time dose. It's an antibiotic. If the patient tests positive for gonorrhea, you treat them for gonorrhea as well with an injectable antibiotic called Rocephin or ceftriaxone. If a patient tests positive for gonorrhea but negative for chlamydia, you still treat for chlamydia, okay? So just important to note that. Other STDs to check for when a patient asks for an STD check or you're worried about, exposures, syphilis, and you can do that through a blood test. You want to do a physical exam on the patient, especially if they mention concerns of symptoms. For example, they have a genital lesion, a penile lesion, or an ulcer. You want to know, is the ulcer painless or painful? You want to check them, although screening isn't actually standard, but I usually like to check for herpes. And then you want to check for hepatitis as well, because you can get that sexually transmitted. So I'm talking about like hepatitis C, hepatitis B, and then you check for HIV. So initially, when you have flu-like symptoms, that's what we call an acute HIV infection. And that generally occurs in the first few weeks contracting HIV. You may or may not initially in the first few weeks find a positive HIV test. So you have to actually retest if you're suspecting it. So generally in this case, if he's positive, we should see the results now. So, you do an HIV test and it's positive. You also, in terms of blood work or the workup, you want to do an HIV viral load, which basically tells you the amount of the HIV virus in the patient's blood. Generally with newly diagnosed patients, you'll see that number is really high. You also want to check the CD4 count. Now, CD4 count is what the immune system numbers are that we monitor. So we want your patient's immune system to be up, and we want the HIV viral load to be down. In terms of actual numbers, if we're looking, we want the CD4 count number to be above 200. Less than 200 means the patient also has AIDS, and that changes your treatment plan a little bit. So let's say this patient came back with just HIV. His CD4 count is 350, so it's in good shape. His viral load we would expect to be high because he's newly diagnosed, not on medication. So say it's 50,000. That sounds scary, but we see that quite often. The goal with the viral load is to get it to less than 20, 20. You cannot get an HIV viral load to actually get it to 0. That means cure. So less than 20 is kind of the marker that we look for. And when you get patients to have a viral load less than 20, that generally means that we call that on being undetectable. And undetectable means untransmittable. So there is over 99% chance that you will not pass the infection on to a partner. So hopefully that makes sense. Those are kind of the common things that you check for. Additionally, what we do is we check for other infections like TB or tuberculosis. We do what's called a quantiferon gold blood test, and you do it once a year for your patients. I mentioned the STD panel. We do a hepatitis panel. With HIV, because they're at higher risk for other infections, you're looking at different vaccines to protect your patients. So you have to make sure that they have the hepatitis A and B vaccines. You want to make sure they have the pneumonia vaccines. There's 2 of them. There's Prevnar 13 and Pneumovax 23. If it's that time of year, like now, you want to make sure they have the flu shot. If they are homeless, they live in a dorm, they are in the military, and generally speaking with HIV, you actually want them to have the meningitis vaccines as well. Naturally, with any patient, you want to make sure they're up to date on their tetanus shot, and that one is every 10 years. So just wanted to add that in there so you guys are aware. So we're looking at kind of a whole picture. We want to make sure they're as healthy as possible. We want to get them started on antiretroviral or HIV medications as soon as possible. So there are a lot of good drugs on the market, and we generally look at or use a 3-drug regimen to combat the HIV. And the reason for that is that each drug has a different mechanism of action, and so it works on the HIV in different ways to help to bring the number down. If the patient had AIDS in addition, you worry about what are called opportunistic infections. What are opportunistic infections? They are infections that someone who doesn't have HIV is not likely to pick up. So I already talked about TB. We screen for that regardless, but we worry about other infections as well, like toxoplasmosis, which is an infection that can affect the brain. We worry about P. cerevisiae, pneumocystis cerevisiae, which is PJP is an abbreviated form, and it can impact the lungs. So what we do to protect patients, depending on what their immune system number is put them on additional antibiotics to protect them. So say his immune system numbers was, or CD4 count was 150, I would additionally, on top of the HIV medicine or the ARVs, which is what's listed here under treatment, I would put him on an antibiotic called Bactrim, okay? And what are the units? It's copies. It's copies per, I believe it's liters. I have to double check. It's copies per liter. So it's actually counting the number of virus copies or viral copies in one test tube of blood. Hopefully I answered that question. The question, sorry, was what units do you use to measure viral load? Obviously, HIV is a very devastating infection, not necessarily because, you know, it's a fatal condition. We are able to combat it. We have a lot of good drugs on the market. Things are very different from where they were 30 years ago with HIV. I have patients living into their 90s who, you know, are not dying from HIV. They're not sick from their HIV. They're sick from their diabetes or heart disease. So it is truly a manageable chronic disease. It is a chronic disease. But, you know, it comes with a heavy load. There's a lot of stigma around HIV, which, we need to continue to work to remove. We need to destigmatize this. It is quite common, as you can see, based on the statistics. We live in an age where we're worried about COVID, the pandemic, but the HIV epidemic is ongoing. I continuously get new patients, new diagnoses of this. So it's important to raise awareness. My goal is to get more primary care physicians to manage this. This is something that is manageable by primary care. You don't have to see an infectious disease doctor. You can, and those are the specialists. They're the ones that usually manage these patients, but it can be hard to get in with an infectious disease doctor, especially if you're uninsured, just like other specialists as well. So I do want to get more primary care physicians involved. So, it can have a heavy load of mental health burden. So, I definitely talk to patients about counseling. So I screen them using that PHQ tool that I talked to you guys about in the previous case. We involve case management if we have to, if our patient is homeless, if they lack transportation, if they have limited food access needs. I say these things because this is what I see in my clinic. If they just need to be monitored to make sure they're taking their medications, we involve case management in that. If they are very sick from HIV, meaning they have AIDS, we want to check in with them more often than just our follow-up appointments. We involve case management in that as well. Regular checkups are key. When a patient's initially diagnosed with HIV, I usually see them every 2 to 4, 4 to 6 weeks, depending on where their numbers are, and kind of going from there. As patients become more stable, they're undetectable, they're doing well, you can even space visits out to every 4 to 6 months. Here's another great question. How has COVID impacted HIV patients? Do they experience worse effects as they are immunocompromised? Interestingly, the data that we found suggests that no, they're not doing worse. If a patient has HIV that's well controlled, then we're not as concerned. We were initially, but we're finding that we would compare them to someone who doesn't have HIV because they're technically not immunocompromised. They don't have AIDS. Yes, I'm more concerned about my patients that have AIDS because they're truly immunocompromised. But in general, I'm recommending the same safety precautions and such. But I have not actually seen more cases specifically in patients that have HIV/AIDS. If I'm concerned, it's more because of their race or ethnic group, because we know that certain groups are disproportionately affected by COVID. We know that already with the data that is out there. But that's a great question. That was something we were concerned for a long time. And we're constantly learning about COVID. Things are constantly changing. So it's something that I try to keep an eye on in terms of the data. So that's a great question. So in general, I just want to say that family medicine, we really provide comprehensive care. We can address many different health conditions. I think of us as first line for patients. We are able to perform annual screenings.
Hi, everyone. Dr. Varma mentioned to me at the beginning that she was having a few Wi-Fi problems, so she may have just cut out for a moment. So we're just going to give it a moment. Thank you all for your patience. Hopefully she's able to join back in. But I think her presentation was coming to a close anyway, so I'm still just going to give it a few moments if you guys don't mind, just to see if she's able to hop back on the video. So thank you guys so much for your patience. If she's unable to join, I will post the link to the Google form in a moment. Don't worry, you will still get your full hour's worth of shadowing. And if you have any other questions, you can feel free to DM Dr. Varma or reach out to her via her socials. Her Instagram is at dr.avivarma. So please feel free to do that. And thank you all for joining our session. Oh, here we go.
Oh my
Welcome
gosh,
back,
I'm
Dr.
so
Varma.
sorry. Yeah,
Oh,
my
no
Wi-Fi
problem
gave
at
out.
all.
Sorry
No
about
worries at all.
that. Did you want me to get
No
back in
problem.
and
Yeah, that would,
share?
if you're able to, that would be great. Thank you.
Good. Yeah, I'm so sorry about that.
No problem at all.
Okay. So I don't know where you guys last heard. I was right when I was about to tip.
Yeah, I think you cut off on maybe one slide earlier.
Okay, let me see.
Yeah.
My screen is still stuck, so I'm trying to figure this out. Let's see if I refresh it. Yeah, it's having difficulty connecting to my screen. Okay, let's see. So it won't connect. My Prezi actually froze, so I might just go ahead and just talk through it with you guys if that's okay, so you don't have to wait.
That's great. That's no problem at all. Thank you so much.
Yeah, so I don't know if there were any more questions on HIV. Hopefully I answered all of those for you guys. I wanted to include that in the presentation because, you know, it is quite a common condition and it's important for us to understand it. You know, it's not just COVID that's happening in the country and the world. We have other epidemics. We have the HIV epidemic, the opioid epidemic. So there's a lot of different things that are still happening, and we just need to remember that. Like I said, or maybe you guys missed it, but you know, I continue to get new cases of HIV, which is, you know, heartbreaking to see. But at the same time, we have you know, great resources and medications that can really help our patients. So I'm very, you know, happy about that. Where I might have left off was just talking about family medicine and how we see, you know, just wanted to kind of recap that we really manage a lot of different conditions. And I hope, you know, the cases show you guys that there's such a variety and diversity in family medicine in terms of what we see. So truly something that is just what I really like about family medicine. Okay, it might work. Let's see. Can you guys see my screen?
I can't see your screen right now, no. Now I can.
Okay. Okay. Let's see if it works. It's a little off, but I just wanted to give some pre-med tips real quick. These are things I talk about on my Instagram too, but basically one of the biggest things, I know it's like a little bit off in it's not centered for some reason, but I wanted to just kind of say that in terms of classes that you take, you don't, or major that you pursue, you really do not have to major in a science field. And I keep reemphasizing this when I talk to pre-med students, because a lot, or oftentimes people think that you have to major in neuroscience or biology or something of that nature. If that's truly your passion, that's great and more power to you. That's what I did. But looking back, I really wish I'd pursued a different degree, because college is your time to explore. And it really is a time for you to check out other fields or get a background in something else. And I'll give you an example. For example, I have some friends that majored in business, and even though they were pre-med, and at the time it was like, why would you do business if you're pre-med? But really, a business degree could help you in the future if you decided to join like, hospital administration, so doing more of a leadership role in medicine, or you wanted to open a private practice. It gives you those tools to be able to help you with that. And if you think about it in terms of applying to medical school, if you have that thought process in college and you have your reasoning, it actually looks better. It looks unique. It looks like you've really thought about why you want to go into medicine, and it shows that you're serious about it. So just something that I wanted to throw out there, because I think there are a lot of unique opportunities and things you can explore in college in terms of your degree. So really keep that in mind. Again, if you still decide biology, that's totally fine. Do what do what makes you happy is what I want to say. You'll still do your pre-med courses. You'll still have to meet your pre-med requirements, and they may vary slightly based on what college or university you're attending. But generally, you have your basics, biology, physics, chemistry, organic chemistry. So just something to think about. I would recommend talking to previous students. Talk about the level of difficulty of classes that you're planning on taking. Plan out your course schedule or your class schedule for the years that you're going to be in college. And things may change around, but figure out a way to balance the classes. So for example, in one semester, you may take one hard class and two easy classes. So really think about that to balance your time so you're not overwhelmed by just coursework. Plus, it gives you more opportunity to do better in those classes, which is obviously important. You want a good GPA. And then hopefully that also gives you time outside of school and college. Like, you want time for yourself. You want to have some fun. You want to also explore extracurricular activities. So definitely plan ahead. And in terms of specific classes, if you've heard or know a class is going to be difficult, plan to join a study group, get a tutor, be in touch with your professor. Having more engagement or interaction with your professor, attending office hours lets them get to know you on a more personal level. In a lot of these science classes, they're really big, meaning there's a lot of students in them. So you may not have as much one-on-one engagement with the professor. They may not know who you are. So those are times when you really want to engage with the professor, and you may even get a good letter of recommendation out of it. So things to really think about. Um, Otherwise, in terms of extracurriculars, I mean, just being here and doing this virtual shadowing with web shadowers is obviously great experience and exposure, especially in the time of the pandemic. Virtual shadowing is important. Physician shadowing, clinical research is going to always be important for you guys. So definitely looking into your universities and seeing what professors are doing in terms of research. And if there's something you're really interested in, definitely think about pursuing that. You don't always have to have your name published in a research paper. Yes, that would be great. But even research where you know you're not going to get your name published, but it gives you experience and it's something you can add to your CV, will look really good. In terms of volunteering, again, I know it's very limited because of the pandemic right now, but generally speaking, volunteering at a local hospital or clinic, um, working with or volunteering for a community service organization, if you have the time, starting your own, um, organization, that would be also helpful. So things to kind of think about. Um, and then in terms of MCAT, again, when I talked about the class schedule, really plan ahead. So plan when you're going to take it. Create a study schedule according to how you study best. Do you study best for like long periods of time, like 8 hours a day, or do you study better like 1 hour a day? So make a schedule according to that. One of the biggest pieces of advice that I can give in terms of preparing for any standardized test is to not use too many resources. Pick one or two good resources and know those well. I was overly ambitious initially when I was applying, when I was in resident or med school and taking USMLE Step 1, and I was overwhelmed by the number of resources that were out there, but I felt like, okay, I'm going to have to get through all of them to really know the material. That is false. So same with MCAT, really pick one or two resources and stick with those and know those well. And then the other big piece of advice is do practice questions. No matter what, do practice questions. That is key. So when you do or complete a question bank or bank of questions, and then you're reviewing them, that's the way you study. Not only are you practicing the questions and understanding how to take the test, but review the questions and answers. So see why your correct answer was correct, see why the incorrect options were incorrect, and really understand that. So it's more than just taking the questions, it's really going through it. Hopefully that's helpful. And really, I want you guys to ask yourself, why do you want to go into the medical field? That's something you will get asked when you apply for medical school. You really need to know why you're doing it. Are you doing it for yourself or someone else? I really want you to do it for yourself. Will medicine make you happy? I want you guys to be happy. Medicine is a very stressful field, but it is manageable. It is doable. But I think my mentality with any job or any career is you really want to love what you do. So I love what I do currently as a physician. I love working in the nonprofit setting. I truly feel like I'm helping people in what I am doing. So it's about finding joy in what you do. Plan ahead, plan ahead, plan ahead. So I already kind of touched on that. Really focus on your goal and do find time to take care of yourself, because one thing I will say, and it's not listed, is if you have to take a gap year, take a gap year. I, looking back, wish I had, but in the moment, I really just wanted to get through everything. I didn't want to be 30 and still studying. I wanted to get done sooner. But looking back, I realized, would it have made that much of a difference if I'd taken a gap year? And you can utilize a gap year to your benefit. You can, gain very important experiences that will actually enhance and boost your CV. So things to really think about. And those are great ways to learn as well. And really, guys, don't give up. If this is your goal, if this is what you want to do, don't give up. I know plenty of people that, they didn't get into med school the first year around. They tried again the next year. They made the most of that year, and then they got in the next year. Same with residency. I know plenty of people who didn't match the first time around, and they waited a year. They gained a lot of experience while they were waiting, and then they got in. So trust me, you guys can do it. I'm trying to see if I can pull up the chat box. I'm not. There we go. But yeah, if you guys have any other questions, feel free to ask me. I'm seeing a question here. What advice would you give to someone still considering med school versus PA school? Do you work with PAs? Yep, I work with advanced practice providers all the time. I work with physician assistants or PAs, and I work with nurse practitioners or NPs. Sometimes I wish I'd gone to PA school. It's less time, less training. And you can, if you're, trying to pursue it more for financial reasons, you'll still make really good money. But you still have to be supervised by physicians as of right now. So there's something to consider. Do you want that independence, or are you comfortable working under someone else? I love my PAs. I love my NPs. They are incredible. So whichever path you choose, just make sure it's right for you and it's something that you enjoy and love. That's all I can really say about that. Do you recommend doing a study class for the MCAT or reviewing on your own? So I think that really depends on how you study best. So I will tell you guys that I took a class. It was like a boot camp for USMLE Step 1, thinking that I did better in group settings. I didn't know any better. It did not work out for me. I had to study on my own in the end, and I realized with that I really study better on my own. So, I mean, I guess I would look at how you've done or how you've studied for previous standardized tests, and did you find yourself to learn more in a specific setting? If you do better in general in group settings, then I would consider taking a class. If you do better on your own, or you feel you're more productive on your own, then I would go that route. Any other questions for me? Well, thank you guys so much for having me. It's been great, and I hope this has been educational and interesting. And thank you again, Web Shadowers, for asking me to come back. It's been great, guys. Thank you.
Thank you so much, Dr. Varma, for taking the time to do this. Your presentation was wonderful, and everyone loved all of your pre-med tips. They're so helpful.
Oh,
For everyone still watching, The Google form for attendance has been posted in the chat box, and you will have 30 minutes from now to complete it. So I'll close it at 1:45 p.m. Eastern. And thank you so much again, Dr. Varma. We're so
Thank
glad to have you
you.
back.
Yeah, absolutely. If you guys have other questions, feel free to reach out to me. I'm trying to pull up my contact. So I have a Gmail account. You feel free to email me. You can check out my Instagram at dr.avivarma. And yeah, good luck, you guys. Take care and stay safe.